Thank you. Thank you, everybody, for joining us. This is such an amazing group of people that I've had the chance of interacting with, and I really, really appreciate it. What we're talking about today is some of the more serious medical problems that we encounter in practice. They're not happening every day, but there are problems that we have to be aware of, and in these cases, deal with quickly. It's not the type of problem where you sit back and say, okay, let me think about it. Let's see how the patient does. Let's do a test, and then, what's next? This is a problem that when you recognize it, you say, yep, I've got to go and act on it. Next slide, please. And sepsis. And sepsis is a really serious major problem. And it looks like, and what happens is when somebody becomes infected, when they get septic, this affects the entire body. So it affects how your patient is functioning, and it can lead and it can affect every organ in the body. You can get kidney failure, liver involvement, trouble with your patient breathing. And unfortunately, this is a potentially fatal condition. So that's why we have to recognize that a patient may be septic. And it's probably one of the times where if we are a little bit overly aggressive and think that the patient is septic when they're not quite there, that's not a bad thing to do. You want to be sure you don't miss the septic patient. And as you'll see, it's just a little bit what we're going to do for treatment. If a patient needs treatment for infection and we're a little bit more aggressive, we're still helping that patient. Next slide, please. Interesting enough, I went on the web to see what has been doing in Kenya with sepsis. And there was a symposium that was held in Kenya in 2019. And this is when they summarized what they were, why they were doing it, what they said. They said this in the public sector, which is where I believe most of the physicians and practitioners that we deal with at the clinic are practicing. There are poor outcomes due to, of course, patients may present down the road. They don't present early on, which makes it much more difficult for you as a doctor. And your resources are limited. So what they want from this thing, they want capacity building, which means we're doing that. We are hopefully, as a group, becoming more aware of what sepsis is. We're going to recognize it earlier. The earlier you think about sepsis, the better your patient's going to do. We want to have a protocol, a guideline. So when that patient presents to you, and you're going to say, I think this patient is septic, this is what I'm going to do. And I know it's either readily accessible. I'm not asking you to memorize everything, but it's got to be someplace you say, okay, this is where I go. This is my resource on sepsis. This whole website is available to you. All these PowerPoint slides, and it has the information in it. And then you've got to know when to send this patient on for secondary and tertiary care, if that is available. And unfortunately, it may or may not be available. You may be, as a primary care, providing all the treatment. But your colleagues in Kenya recognized what is a worldwide problem and is a problem in Kenya. Next slide, please. Okay. Why does a patient become septic? It's due to usually a bacterial infection. So your patient has been exposed to a bacteria. It could be they had a wound that became infected. They could have eaten something which was infected and exposed them. However they became infected, it's usually by bacteria. Now, there are viral causes, and it's usually underdiagnosed, what we can treat most effectively, we'll see, those are caused by bacteria. Next slide. So there is some information about viruses, and we're including now, of course, COVID. There are other viruses, the influenza virus. These are commonly detected viruses, but they're getting new infections, and it's been a global health concern. And I'm sure everybody has dealt with COVID and knows that we do have protocols for COVID. Unfortunately, not as well tested and worked out as the bacterial protocols, which have been around for many, many more years and are usually more successful. Move on, please. Next slide. Okay. What is it about your patient when they present that it's going to trigger you to think that my patient may be septic? You know, if your patient walks in and says, hey, I just don't feel well and I'm a little tired, I think I've had a little bit of a fever, sepsis is not going to be necessarily number one diagnosis. But a septic patient, the blood pressure, they're going to come in, their blood pressure is low. They're having a very rapid heart rate. They've got a fever usually, not always, but usually. And if you do some blood work, you find that their white count is elevated. And within the white count, those cells that respond to bacteria are predominant. Now, as things go on, because this patient may not have been presented earlier, or they may have to travel to you and become worse over the travel, the next step is you go into shock. You could become cyanotic, your skin now becomes cool, you stop producing urine. Mentally, you could be different. Now, this is a complete picture. But also, you know, this does not only present with sepsis. You've got to think of, does the patient have pancreatitis, for example, or respiratory distress syndrome? So you're looking at the entire patient. And what I tend to do, and I think most folks do it, is when we take our history, we get as much information as we can. And when we do our physical examination, it's not a focused exam. You know, we're not just focusing on one organ, we're doing a complete physical. You see, as you move on, you can have altered mental status. If you have that realization, you may have to get some of the information from the person who brought that patient in, from their family, their friends, whoever, you know, accompanied the patient. Because if I have an altered mental status, I'm not going to be able to provide you with the information that you really need. And when we go back and we say before about the presentation with fever or an elevated white count, I always use myself as an example. I happen to have lost my spleen in an accident. I am at risk because I don't have a spleen to get sepsis if I get an infection. And I was on a volunteer mission in a refugee camp in Greece, and I started to feel poorly, and I was told by my doctor, get checked out and get antibiotics right away. So I go to the local hospital, speak to the ER doc, and they say, sure, we'll do some blood work on you, check your fever, and we'll give you the antibiotics. After I finish the course of antibiotics and I'm ready to leave, because I would, if I hadn't responded, I would have to have more, but it's only one course. The head of the emergency room comes over to me and says, you know what? You can't be septic, your white count is normal. No, 30% of people who are septic can have a normal white count. They still may have changes, but my white count doesn't have to be 18,000 or 25,000. It still could be 8,000 or 9,000 within a normal range, and I still could be septic. Part of the problem with all doctors in medicine is keeping up. And hopefully that's one of the reasons we're here, so that all of us stay up to date. And we realize this patient who came in with fever and an elevated heart rate, and he's hypotensive. Okay, he has a normal white count. That does not rule out sepsis. Next slide, please. Okay, physical findings. Now, what they say is that you may have findings that are related to the underlying cause of sepsis. So if I had pneumonia and the infection now spreads to my entire body, it's not confined just to my lung, and I become septic, I could still have a cough, I could be short of breath, I could be in pain. It could be that my cause of my sepsis was a wound which became infected. So then when you looked at me, you would see the area that was infected, and that was the start of the sepsis. I can present, depending on where my infection started, with changes in that system. Pneumonia, the rouse in the lung, the wheezing, diminished air entry, usually localized. This here, it says a surgical wound, but it could be a traumatic wound. Somebody's out in the bushes working, they cut themselves, they branch scrapes them. It could be an animal bite that got infected. Now, what are you looking for? You're looking for, one, what's their blood pressure? Do they have hypotension? Defined as your systolic less than 90 and mean arterial pressure less than 70. And this is a good guideline to go with. Next slide, please. Other physical findings. Temperature can be elevated, greater than 38.3, but it could be normal still, less than 36. Look at your heart rate, usually greater than 90 or more than 2 standard deviations above the normal range for age. Don't know if you folks have, and I can provide you and get it. Look at your chart with what is the normal range for age. Something you keep, in a drawer, posted on the wall. So when a patient comes in and they've got a heart rate and they're 17 and they've got a heart rate of 112, you're going to say, is that within the normal range? If that patient was 80 and they had a 112 heart rate, where is that? Usually, to move on, the patient is breathing rapidly, greater than 20 beats per minute. If you look at their skin, it's warm, it's flushed early on. But then if they start to go into shock, depending when they present to you at your clinic, now the skin becomes cool. Because what happens is in the body, our body says, okay, our organs are shutting down, they need more blood. So the body directs the blood flow away from the skin. Skin's not as warm, it's cool, because the internal organs are getting it. So if you go and you put some pressure on a part of the skin, it doesn't return to normal color because the blood flow to that area is decreased. You could be cyanotic. We talked about the altered mental status. I could just be restless or not. My urine output, it may stop or may become increasingly diminished. So those are all, so when you ask me in my history, have you been avoiding, have you been going to pee as frequently? I may say, no, gosh, I realize I haven't gone today. It's in the afternoon. I got up this morning and I went a little bit and I still feel terrible, but I haven't gone as much. Another clue for you that your patient may be septic. Now, there are other causes of low urine output. This is just one which you put together to have the entire picture. Next, please. So what can happen, and this is looking at physical findings, you may have a patient, and this is where it's important for you to know about your patient, medicines they're taking, their past history, their surgeries, because if I have a diabetic patient who comes in, who's on a beta blocker prescribed to them, their heart rate may not respond to the body's developing sepsis. The younger patient may develop rapid heart rate, but not become hypotensive till later on in the course. If you have chronic high blood pressure, which a lot of seniors do, you may now have problems with hypotension at higher blood pressure. Next slide, please. Okay, what do you do in the lab? You've done your history, you've done your physical, you say, this patient may be septic. Next slide. Let's look at the lab test. Okay. Oh, sorry. Okay. Now, there is no one lab test which is going to say to us, my patient is septic. You put together, just like you've looked at your history, and at the end of your history, you say, no, my patient may be septic. You do your physical. Yep, that confirms that this patient may be septic. Now you look at your lab work. They're non-specific. So you may have other illnesses that are causing your patient's problems, but these are the guidelines. A white count, usually greater than 12,000 or less than 4,000. So you could have either end, a leukopenia, low white count, but a normal white count is possible, but 10% usually of the cells, when you look at it, are very immature. You often can get hyperglycemia, a blood sugar greater than 7.7, but the patient's not diabetic. So here somebody's presenting, they have all the other symptoms, and you said, okay, I'm doing a white count, I'm doing sugar. Now, I don't know how often, and this is where some of this information may not be germane to every site. But if you can get a C-reactive protein, it's usually 2 standard deviations above what the norm. If you look at their oxygen level, arterial, it's diminished. And if you're going to measure urine output, and often when you get a patient who's coming in, you think it's septic, you're going to be catheterizing them because you want to know, as you replace fluids down the road, as you treat them, what's happening to their kidney function. And although you can measure it by having them void into a container, it's a lot easier if you can very safely put in a catheter, and then you know what their urine output is, even as you're resuscitating. Next, please. If you can get blood cultures, these are all ifs. I'm assuming, I'm giving you the ideal situation. You got to look at your site and what you can do. You take blood cultures from two separate sites, 2 arms, the arm and the leg or the foot, wherever you can find blood vessels, but don't do it from the same site. Make sure when you collect, or whomever collects the blood pressure, you do it properly. And if you can get that, that's important. That's important because it may give you the precise organism that is causing your patient to become septic. You're going to see why that's important in a few moments. Next slide, please. Okay. Do you need to do any imaging studies? Not really. If you think that a patient has pneumonia, you can do a chest x-ray. But if a patient is displaying all the sites, all the history that we talked about, all the physical findings, the other lab tests, and you don't need to do that chest x-ray. You listen to the lungs and you're hearing the abnormal findings. There's no need. If it's easy to do, great, do a chest x-ray. We're not talking about sending these patients for CAT scans, MRIs, ultrasounds. It doesn't help the patient, and you don't need to use that valuable time when you can starting to treat your patient. Next slide. Okay. You know what? It's ideal to know exactly what the organism is. However, when they look at people who are known to be septic, half the time we can't identify what that organism is. You've done your blood cultures appropriately, you've used 2 sites, you've done them anaerobically and aerobically, you've done all these other blood cultures, you may not find an organism. On the other hand, you're still going to treat that patient. So we still try to do it, but a patient can still be septic if they've got all the other findings that we talked. Next slide, please. Why I chose sepsis is that a lot of our patients die once they become septic. And it is really crucial that we start treatment of our patients once we have reached that conclusion ourselves. As I said before, it may not be correct, but this is one of the times which is different when we talked about a little while ago in a different presentation how antibiotics worldwide are used inappropriately. This is one of the times where it is very appropriate to start with broad spectrum antibiotics right away. Time delay could be fatal for our patients. Next slide. Okay, how do we manage it? We've now got together, we've got our patient presented, we've got our history directly from the patient or from people who brought him in if there's been an altered mental status. We've done our complete physical examination. Don't forget, when we do it, to do the neurological exam. When I look at medical students, or again, to use myself, I had to have neurosurgery. The residents, before I had the neurosurgery, came in to do my history and physical. They did not do a Babinski. They did not check for peripheral neuropathy. My business history was normal, but I've had a peripheral neuropathy for unknown cause for 30 years. They totally missed it. I'm going for a neurosurgery in, part of neurology. They didn't do it. Do a complete exam. Doesn't take too long to do a sensory exam if the patient is mentally competent, and usually they are. It takes very little time to do a Babinski. It takes very little time to do all these other tests of our look in their fundi in their eyes, do the other full examination evaluation. Not wasting time for your patient, and that should be done right away. Okay, let's move on to the next slide. Okay, you've got to rapidly give the patient fluids and start antibiotics. So you're going to start an IV, make sure you have a good IV. Often when patients become septic, it is difficult to plant an IV. They're shutting down their peripheral circulation. It's hard to find. If you can place a central line safely and easily, great. Don't have to. And often people start 2 IVs just to be safe. Because if one stops functioning, you've got the second. Next slide. Okay, this is a long slide. I'm not gonna, what it says is we don't know how much fluid to give. We know that we should give fluid, but if you try to look at what type of fluid and how much, I can't give you a good guideline. I would use half normal saline. You can do D5, half D5W, whatever you want for fluids. You just want to get fluids into that patient. And there's no guideline that says one is better than the other. So, and as I said, these PowerPoints are available. This is a lengthy slide, there's too much on it, but this gives you the rationale for saying just get fluids going. Next slide, please. Okay. You think of where that infection could be, and you choose your antibiotics to try and get at that site. So if you think your patient may have an abscess in their body, you're choosing antibiotics for abscesses. If you think that your patient has pneumonia, you're treating pneumonia. You may not know a site. So you want to do a broad spectrum, and you want to start those antibiotics within 1 hour after the patient comes to see you. So we're asking the lab to quickly give us results in a priority because we've got a potentially very, very sick patient. We're asking, you stop doing other things. You've done all the things we talked about on this patient. And within the first hour, even maybe if you don't have your lab work back, you start this patient on an antibiotic. This may save their life. Next slide, please. Okay, how to decide? As I said, you go by your history and your physical. If you can get preliminary lab, beautiful, but it's your history and physical which is going to guide you which antibiotic to use. Next slide, please. Okay. What you want to do is choose a broad spectrum antibiotic. An example is a piperacillin as listed in the bottom of the slide. You want something that's gram-negative, gram-positive. If you're thinking of fungi, like Candida, you want an agent against Candida. But you want to cover initially for bacteria as broad a spectrum of antibiotic as you have available at your site. Next slide. Okay. And what are the organisms that commonly cause somebody to become septic? E. coli, Staph aureus, Klebsiella, Streptococci. So you want to think that these are, as far as most cases of sepsis, these are the bacteria that are going to be there. These are the bacteria that are going to be affecting your patient. And so when you choose, you want to choose one that covers as many of these as possible. And you may have to use more than one antibiotic. Dual antibiotics is perfectly acceptable. Next slide, please. Okay, as I said before, combination is recommended. And that's using 2 different classes, because this way you can accelerate how fast we attack that bacteria and how fast the patient goes along. What does it say? 2 antibiotics are perfectly acceptable. If you want to use only one, or if that's all available to you, I know that you're in what are available to you for resources. You have to go by what's in your site. Unfortunately, and one of the difficulties with international telemedicine is I'm learning a lot about Kenya, but I don't know what you have. And also, I can give you generic names, but a medication may be called one thing in the United States, where I get a lot of my slides from, and something different in a different country around the world. Next slide. Okay. When do you stop or narrow down what you have? You've got your patient on IV fluids. You've got your patient on 2 separate broad spectrum antibiotics. You've got your blood cultures waiting to come back. You've got your lab work. So what do? How do you know what to do next? And it's basically your evaluation of how your patient is responding to therapy by looking at all the guidelines that you have available to you. What guidelines am I talking about? Their clinical response. What is their blood pressure doing? How is their heart rate? How is their oxygenation? How is their mental status? If you see an improvement in all of these areas, you know your patient is responding. And if this starts to show ongoing benefit, then you can say, okay, I'm using 2 antibiotics. Maybe I can cut back on dose if you've used a very high dose, or get to the point where you cut off one and say, I only need 1 antibiotic. This is your clinical judgment, and this is where it's difficult. Next slide, please. That's it. I think we're there. I hope this is of value. Please, if there, I know there's some questions and we'll go through them to the best of my ability. If you need or want me to provide other information that I haven't, and I know I've gone quickly and there's a lot of information, this is a really important topic because you don't see a septic patient every day. But when we do, we want to recognize it. And if you look statistically about the burden of illness around the world, Kenya and your related neighbors have some of the highest burden of medical problems in the world. So I look at the cases which I'm presented with, and I am seeing patients who are presenting with much more severe illness. People who have an anemia. When I was in medical school, I had a patient who came in at a hemoglobin of 4, I'm using the grams per liter, and I don't know how that translates. That was rare. That was hardly. I've had at least in the last 6 months, 2 or 3 people who were walking and presenting to you with hemoglobins of 5, and 1 woman with 3. You've got extremely ill patients who are presenting much more frequently than I saw them. So for you as practitioners, you're more likely to see a septic patient. If there's any more information that I can provide, please leave it in the chat. Malik is phenomenal. He'll remind me, beat me over the head to make sure that I send you what you require, and I'll do it as quickly as I can. We did it after the last presentation. I think I got the information to him within like 5 minutes when he asked the question. I'll try and do it the same for you. Mel, can you handle the questions, please?
Absolutely, Dr. Hart, and thank you so much for this introductory lesson into sepsis again. And on your previous webinar, after you shared that information, we had over 24 people look at the extra resources. So thank you so much for sharing them. We'll go ahead and get started with the questions. And since this is such a different topic, if anyone has a sepsis story they would like to share live, just please raise your hand and we'll call on you. And you can share your story with sepsis. So the first question we have is, high ESR levels, is that a finding of sepsis?
It could be. This is because that is, we talked about before doing other markers, and that is one marker, which could be. If you're lucky and you had one, if you had before and had a normal ESR, that makes it easy. But yes, a higher ESR can indicate. And don't forget, as we said before, and I don't want to belabor the point, it's not one test. You're taking this information, which is very valuable, and you're combining it with the white count, the history of the physical, all the rest of that. Yes, if you can get an ESR, that's beautiful. Because you cannot often, that's a great test to get, and I rely on that often. One story about an ESR, which is a very, personal story. My late father called me years ago and said, I've developed diabetes. It's in my family. And by the way, my ESR is elevated. And I remember thinking about that and going to my resident, I was a medical student at the time, and saying, I don't think, and I couldn't find that a raised ESR is part of diabetes. She said, no, it's not. That was his first indication of cancer of the kidney. The doctor never looked at it. A raised ESR is a valuable test, and in the setting of sepsis, it's an extremely valuable test. You get a patient who you think is septic with a raised ESR, you proceed to treat. And it'd be interesting to repeat that ESR. I personally had cancer of the kidney. My ESR was up when it was diagnosed. When they took it out, and this is 10 years ago, it went down to normal. Excellent test, an excellent question. Thank you.
Thank you, Dr. Hart. What is the best fluid for sepsis management?
There is no best fluid. That's what that slide was trying. I didn't say it properly. If whatever you have easily on hand as a general resuscitation supportive fluid, you use. E5W, normal saline, whatever your site carries and you can give to that patient. There is no proof that one fluid is better than another. We know for antibiotics that broad spectrum are better. We know that if we start within 1 hour, we're going to get better results. But they don't know which fluid, and it was recommended in that slide, which you'll get when you get the PowerPoint, that we do studies to try and find out. So it's a great question. We don't have a great answer.
Wonderful. Dr. Hart, is it recommended to catheterize a patient that you're treating for sepsis?
I think it is. If you can safely catheterize your patient, you can monitor extremely closely their urine output. If a patient is mental status is failing, they're feeling weak, are they going to necessarily alert you when they have to void? They may void and not think about the fact that they have to tell you, or start voiding, say, oh, no, I've got to get a bedpan. So if you catheterize them, you eliminate that problem for them, and you now have an accurate output. Because if you find that your urine output is falling, then you know that you've got more kidney problems. That will also guide you in fluid management. You don't want to you don't want to overload your patient. So that's one of the measures we're using is fluid output, along with blood pressure, etc. Thank you. Next.
Absolutely. And in the same vein of patient management, would you also recommend putting the patient on oxygen?
Yes, there is no harm in doing that. You initially would do a pulse ox, I'm sure, when that patient presents, as long as that's easily available. Sure, you put your patient on oxygen, you help with their tissue perfusion by doing that. And you use a 2 or 3 liter low flow oxygen. It's not necessary to use high flow. We're not talking about a patient going into respiratory failure or that. Excellent question. Yes, you should do that.
Absolutely. And the next question is, in some places in Kenya, the blood culture may take days for results to come. Do we need to delay treatment as we wait for the culture
No,
results?
never wait for the blood culture. What your blood culture will do for you is you draw it right away, start your patient within the first hour. Nobody's going to get a blood pressure back. You can't even grow that quickly. But when that blood culture comes back, it may say you have Klebsiella pneumonia as your organism. Now you can look at your antibiotics and say, okay, I'm treating multiple. Let me choose the antibiotic which is appropriate and specific for Klebsiella, because I don't need to expose my patient to the risk of a broad spectrum antibiotic. So that is the value down the road to help you manage. If you don't draw a blood culture, if you can't get it, that's okay. You're still going to manage your patient clinically. That is a nice piece of information to have if you can do it, and you never delay treatment. The same with your white count. If you're going to do everything within an hour, start that patient on antibiotics, you just have enough time to do the appropriate history, physical, get your IV started, get your lab test set off, and then you're starting antibiotics. That is your first hour. And then as the lab tests come back, if your patient turns out to be anemic and has a 4 or a 5 hemoglobin, you say, okay, I've got to transfuse this patient. You add that to what you're doing. If your patient turns out to be is a diabetic and has a 10 or 11 millimole blood sugar, you then manage that by some insulin. So there's, as you get more information in, you manage, but you never wait with a septic patient for that information to come in. Now, if it's it sits in contrast to your regular diabetic who comes into and it says, I'm here to follow my diabetes, and you do the blood work and you wait and it comes back elevated and you sit and talk about it and you say, this is how I want you to proceed. No, completely. This is a one time where you act and then get information. And then you modify what you've done based on the information. Next slide, please.
Thank you,
Next
Dr.
question,
Hart. In
Heather.
the US, I know a lot of medical schools and hospitals tell you that every minute counts with sepsis, and that's the general guideline. The next question is, can sepsis cause shock? And just a secondary question, what are the warning signs of septic shock as well?
Okay, yes, sepsis can cause shock. Septic shock is if you look at it as of what can happen or how something develops. The patient becomes infected, they become septic, the body starts responding, it fails to respond, the bacteria are winning the battle, so to speak. They go into septic shock. So what they've come in, as you go into septic shock, your blood pressure starts dropping, you've got the pale skin, you become much weaker, your heart rate is racing, you're breathing more rapidly. All of the signs of how your patient is doing become go to the negative side, rather than your patient, feeling better, fever dropping, heart rate dropping. So, and it's a progression. You try to develop your treatment early on to prevent that progression. Your patient may have traveled to you from a distance and become septic before they left where they live. And during that journey, they could have gone into shock. So your patient may present in septic shock. The treatment, you know what to do. You take as much history as you can. You do the complete physical, which you can do quickly but thoroughly. And you start your IV, and you can have your assistants starting your IV while you're doing your physical. There's no reason why that can't be done. And you can, if you formed in your mind the opinion that this patient could be septic, you've told your associates, your nurses, or whomever, tell the pharmacy this is what we need, or if it's in your emergency room, please draw up these antibiotics. You know that this is in your mind, you're going to get it going. So these are great questions, and I'm trying to stress this is urgency. We want to get this patient treated quickly. It's a different mindset than what we're doing when our average patient comes in and I've got a cough, and yes, there's pneumonia. Yes, we treat that patient, but that pneumonia patient, we're giving pills to go home with. This patient who may be septic or going into shock, we're studying our IV and giving him within an hour IV antibiotics. Next.
Absolutely. Thank you, Dr. Hart. The next question is, how do you diagnose a viral sepsis?
Hard. We're talking about influenza. Well, I think what you may be presented with, influenza, COVID. You diagnose this by your history and physical, and trying to put, we know how people with COVID present. If you're thinking of COVID, you do a COVID test. If that comes back positive, okay. And as you know, people with COVID can go into shock. People have high mortality rate, especially in the unvaccinated, non-immunized. So that's by some of your testing. A COVID test, at least where I am, a few minutes, you can do a rapid nasal swab, get a response. So if that should be in the back of your mind, when you're seeing this patient who's coming in, who's ill, because COVID is a worldwide problem now, you're going to say to yourself, this patient has COVID. Okay, test them for COVID, but carry on, because that COVID patient may need antibiotics anyways, with what other treatment, your supportive treatment you're going to do. So a great question. For influenza, if that is, you'll know often what illnesses are present in your community. And if there is an influenza A or B outbreak, you'll know it historically from what's happening in the community. And that will be another reason to alert you to think about that in your specific case. Next. Please.
Dr. Hart, can chronic tonsillitis be a risk factor towards sepsis?
I don't think so. I'll have to look it up. And chronic tonsillitis is an interesting illness, because I don't know if we're talking about a patient who we keep culturing and getting back a positive culture. The guidelines that I'm familiar about in the United States for tonsillectomy are 2 positive strep cultures separated by at least 2 to 3 weeks or a month. So, often for children, the child presents, you look at them, they've got a red inflamed tonsils, maybe with exudate. You do a swab, comes back positive for strep, you put them on, if they're not allergic to penicillin, you put them on penicillin, they get better. 2 or 3 weeks later, they come back. doctor, I've got another sore throat. And you look down, there it is, red infected. I don't know if that's the type of patient we're talking about who keeps coming back and is recurrently infected. Those may be an indication to get a tonsillectomy versus a patient who has, you look down and the tonsils are chronically red. That I don't think is a guideline or sorry, an indication or a risk factor for sepsis. Next, please.
In a patient with BAC confirmed PTB with signs of sepsis, can a broad spectrum antibiotic?
Sorry, can you go over that again? I'm
Sorry,
sorry, I just.
No, absolutely. I'm power reading here. In a patient with a back confirmed PTB with signs of sepsis, can a broad spectrum
PTB is
antibiotic?
what? What's PTB? You talking about tuberculosis?
I'm honestly not sure, Dr. Hart. The question came from Seth Kagia. Seth, if you want to unmute
If you could
yourself
ask it,
or
because
clarify your
that's an
question.
abbreviation that I personally am not familiar with, but we all use different abbreviations. Good, Seth has got his hand up. Can you tell us what that is, Seth, please, and what this about the situation?
Yes, I hope you can hear me.
Oh, yes, I definitely can. Thank you.
Thank you. The good one. That's a nice presentation. We've learned a lot. So my question was, in patients who've been confirmed to be having pulmonary tuberculosis,
Right.
and through the gene expert or smear, and these patients are presenting with the signs and symptoms of sepsis, the way we've just highlighted in the presentation. In our setup, we tend to give other antibiotics, broad spectrum antibiotics, just to see, because we are not able to do cultures and have the results within the specific time. So we tend to cover with the broad spectrum antibiotics. And I just wanted to know, is it a good practice? Can you advocate for that as the way we are doing?
Oh, yes. Yeah. When you, okay, so he is pulmonary TB. Thank you. If you get your patient who has known TB and is coming in septic, yes, be from the TB, it could have had another source of infection. Excellent question. And you start treating them as you treat any patient for sepsis. I do not know how the situation for multi-drug resistant TB in Kenya, that's something when your patient comes to a septic who's known TB, is now are they developing a multi-drug resistant TB, and that has to be in the back of your mind. And I don't know what you have for treatment there in Kenya. I know there are 2 drugs, I forget, names are not the top of my mind, that have now been brought out to try and help these patients. And they're in the US, I know they're in India. I don't know of the availability worldwide. I can find that out, get you that information to have. But that you would definitely do what your protocol of saying, yes, I'm going to treat that patient with TB as septic with antibiotics. I agree with that. Next.
Wonderful, and thank you so much for that question. The next one is, we know patients with diabetes are always at risk of diabetic ulcers. Do we change the treatment in such patients?
No, well, yes and no. If the patient has a diabetic ulcer, you're going to treat that ulcer aggressively. If you now feel that that patient is becoming septic, and that is the source, the ulcer, in fact, the infection in the ulcer is a source of a sepsis, you've got something to culture. You've done your blood culture, you can culture that ulcer. You treat the patient for sepsis, as we talked about, multiple, at least 2 broad spectrum antibiotics. You then get your culture back, and that could give you a guide to narrow your antibiotic. But yes, diabetic patients are really at risk. They have ulcers or infection. Great question.
Wonderful. The next question we have is, in complete blood counts, which parameters do you really need to concentrate on in a septic patient?
Good question. White count is probably the most helpful. And either you're gonna get for a septic patient, the problem is for a septic patient, there's no absolute. They're good 30% plus or minus could have a normal white count. In the slide that we had before, it talked about a white count of over 14,000 or less than 4.5. The body responds one or two ways. In general, the white count, the cells go up in a marked fashion to fight the infection. Sometimes the body doesn't respond and the white count drops to less than 4.5. You've got the two ranges. You've got to use your lab test in conjunction with your history and physical. And don't forget, our goal is to start treatment in an hour. You've drawn that lab test. I don't know what the turnaround time is in your facilities. I know I have practiced in patients where the turnaround time maybe 2 or 3 hours before you get back your full lab studies that you've drawn. You've already started your patient. You then look at your lab results. If they come back and say, yep, that seems to confirm. But if clinically you say this patient is septic, their blood pressure is low, they're not perfusing well, they're tachycardiac, they've got some altered mental status, they've got a possible source of infection, there's an ulcer there, an abscess, pneumonia, you have pyelonephritis, kidney infection. You then say, okay, I've looked at this lab result, but I'm looking at my patient. My patient is septic. So if it comes back with a normal white count, you don't stop treatment. You say, okay, I've got this point now. And don't forget, at least what I would do is the next day, it's easy to get a follow-up white count. Get a follow-up white count. You're going to be, just like you're monitoring your blood pressure on a regular basis, you're going to monitor some of your lab tests on a regular basis. And say, just like you're going to monitor your renal function. If you can get easily a BUN, a creatinine, et cetera, you're going to look at your electrolytes, you're giving them fluids. Do they have adequate potassium? Are they becoming depleted in potassium? You don't want them to become hypernatremic or even sodium. So you're going to monitor all these for your patients on a regular basis. You're going to monitor your white count. You can see how the body is responding. Next, sorry.
Wonderful, Dr. Hart. We have 3 more questions, and I'm afraid we may only have time for one more. So
Okay.
I'll skip to Felix's question. In a full hemogram report of an infant with high lymphocytes, does that count, or high lymphocyte count rather, does that qualify for a viral illness process?
It could, definitely. But don't forget, the lab test is not diagnosis. Lab test is an aid to you as a physician, as a provider, in conjunction with everything else you're doing. You've got, you've got that physical, you've got your physical examination. You're looking, you've got the history of what's going on in the community. And if you've been seeing a lot of viral illness, and this is how they're presenting, great. But that's only one thing. There's no one lab test. There's no one marker. It's unlike diabetes. You get a patient who comes in with a very elevated blood sugar, never been diagnosed with diabetes. You can make the diagnosis of diabetes really easily. In that case, the lab test is diagnostic. In this case, it's a guide. It's a guide to it, maybe a viral illness. And if you start thinking, what viral illnesses do we have? Oh, COVID. Patient for COVID. And that is where I guess all this comes. Hope that's been of value.
Dr. Hart, as usual, this has been an incredible conversation. And I think this is the most engaging conversation we've had so far. 14 questions, and we still have 2 to go. To Risper and Joyce, I'll send these questions to Dr. Hart after the call. And to everyone who's listened to the call, a copy of the slideshow and Dr. Hart's notes will be made within 72 hours on our YouTube channel. And also look forward to an email for a link from Zoom as well. Dr. Hart, as usual, thank you so much for the amazing presentation, and I'll turn it over.
So this is a real pleasure. Thank you for all your participants, and I hope they're having a safe and very good day. Thanks a lot. Bye now.